In 5, 4, 3, 2, 1.
Uh, Good evening, everybody. We are discussing today about the peripheral arterial disease, rather PVD, otherwise peripheral vascular disease, because it is a very common entity which we come across regularly. Often it is a major, rather it is distressing disease also. And for students' point, it is a long case. Will be kept and a lot of short notes, MCQs, and theory questions also will be asked. So exam, it's a main case. That's why it's very important. Both UGs and PGs. So UGs are presenting today. I welcome uh, my senior professor, my teacher, mentor, whatever, sir, G. Manohar, sir, from Manakula Vinayagar Medical College, Puducherry. Sir, welcome you, sir.
Yes, sir.
I welcome Professor Muthakumar from Savitar Medical College, sir. Welcome you, sir. Sir is sir students are presenting today. I welcome my dear friend Robin. Robin, welcome you. Keshav Prasad is on somewhere on the way. He said might join because not at reach home. So in this absent, I welcome him. In between him, you join. I welcome students uh, Abhirami J and Shahin Ali JS, who is presenting today's case. They are final MBBS students from Savita Medical College, Chennai. Welcome one and all our viewers from different colleges, different places of this country and elsewhere. So without wasting time, sir, Manohan sir,
Yes,
Muthukumar,
sir.
we'll go ahead with the presentation, I think. So
Yes.
with all these senior faculties permission, we'll go ahead with the presentation. So Abhirami is presenting the history. So over to her.
Good evening, respected faculties, and thank you for giving me the opportunity to present. So, I would like to start.
Next slide, Pritika.
So, the patient that I've chosen is Mr. Vibhishnan, 63 years old male from Nemili, Arakonam, who is currently unemployed, came with complaints of pain in the left foot for 1 month and blackish discoloration of left great toe for the past 15 days. History of presenting illness. The patient was apparently normal 1 month back, after which he developed pain over the left foot, insidious onset, cramping type of pain, gradually progressive in nature, continuous pain, which is non radiating, aggravated on placing foot on ground, not able to walk, relieved by hanging the foot down. History of blackish discoloration of left great toe for 15 days, insidious in onset, initially involved only tip of toe, later progressed to involve the entire plantar aspect of left greater toe. No history suggesting intermittent claudication, pallor, bluish or dusky red discoloration on exposure to cold. No history of pain over the course of the vein. No history of pain in the buttock, thigh, and other limb. No history of tingling sensation or numbness over left foot. No history of trauma or discharge from blackish discoloration. No history of chest pain, palpitations, or shortness of breath. No history of transient loss of consciousness or transient loss of vision or blackout. No history of transient weakness of limbs. No history of postprandial abdominal pain, loose stools, melena. No history of gluteal pain or impotence. No history of upper limb pain. Past history. History of similar complaints in the past. Known case of chronic myeloid leukemia since 2014 on tablet imatinib. Known case of diabetes mellitus for the past 2 years on tablet metformin. Known case of systemic hypertension for the past 8 months on tablet telmisartan. Known case of spinal tuberculosis, diagnosed 2 months back, on anti-tubercular treatment taken for 1 month but stopped 15 days back by self because of vomiting. No history of coronary artery disease, cerebrovascular disease. Treatment history: tablet imatinib, tablet metformin, and tablet telmisartan. Surgical history: right grade toe raise amputation done 2 years back after thorn prick which progressed to ulcer, then turned in blackish discoloration. Family history: no history of similar complaints in the family, no history of coronary artery disease or cerebrovascular disease in the family. Both the parents are deceased. He is one among three children. Uh, his wife is non. His wife is not. His wife doesn't have any similar illnesses, and he has two sons and one daughter with not known pathologies identified. Allergy history: not known allergy to any drugs and food. Personal history: no history of smoking, no history of alcohol consumption, mixed diet, disturbed sleep for past 1 month, normal bowel and bladder habits, no loss of weight or loss of appetite noticed in the patient.
Next slide, Subisha. Then.
History summary: 63 years old gentleman who was a security by occupation previously, now unemployed, is a known case of chronic myeloid leukemia for 15 years, type 2 diabetes mellitus for 2 years, systemic hypertension for the past 8 months, came with complaints of left foot pain for 1 month. History of wrist pain, blackish discoloration over the left great toe for 15 days, with no history of cerebrovascular disease or coronary artery disease. Probably a case of peripheral arterial disease of left foot, specifically the left great toe, due to diabetes mellitus, which is also a cause of atherosclerosis.
We'll go. No, no. We'll go back to the history. Go back. Go back. Go back to the first slide. Okay. 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 Here only. Okay, sir. Anything to comment? Pain. There is no claudication, is it? Intermittent claudication is not there. There are.
No, sir, it is not present, sir.
Okay. I think, Robin, whether if there is not there a negative history, there should maintain the chief complaint, not necessary, I think, no? Because the intermittent claudication was not there.
No.
Oh, okay.
Yes.
Okay. Pain.
Still, yeah.
Only 1 month duration, is it? Every 1
Yeah.
month?
Yes, sir.
Okay. Next slide. Next slide. You said cramping pain. What is that cramping pain?
Sir, for the last 1 month, the patient had a little cramping pain, sir, to an extent that the patient was not able to walk at all, sir. So it directly presented with grade 3 of the claudication, the rest pain.
No, breast pain is not a claudication. Breast pain is not a part of claudication. No. Claudication has got three grades. Breast pain is not a
Yes.
component of this one. Whether patient is has had claudication and then became breast pain, had pain, breast pain, or straight away developed breast pain without claudication is the question.
The
Are you able to
patient,
clear that?
yes, sir. The patient did not have claudication pain previously, sir.
What is
The
claudication?
patient,
Intermittent claudication means what?
it is the pain that comes due to the insufficiency of oxygen and blood flow to the particular muscles, sir.
So what is how will you define it? What exactly it is? A crampy pain in the
Claudication actually means the exact term means limping, sir, but the patient presents with cramping pain. So after a certain distance, the patient has walked due to
No,
insufficiency of.
No, that's not the question. The question by sir is how do you define claudication? That's all. So it's a very simple three things. Three criteria should be there in your definition. Simple as
criteria.
that.
That
Height,
three
cause,
criteria.
and a factor. That's all. Very simple.
So what are the three criteria to define intermittent claudication?
I not. Your voice is breaking, sir. Robin, sir, your voice
Yeah, yeah.
is
Abhi,
breaking.
there are three criteria for sir's question. When you want to
Okay.
define claudication, there are three. So just to make it easy for you, just learn site,
Yes.
cause, and a factor. That's all. Simple. So sir's question is how do you define? So claudication is defined as pain where? Which it's not in the foot.
In the yes, sir. It is in the muscle uh,
Hey,
due to
site.
vas.
Be
Yes,
specific.
sir.
No, no, not you. Huh?
Left great toes, sir.
It is a cramp-like muscle, whether it is in the calf region. That is the site of your problem, right? When the
Yes.
muscle is exercised, when it's moving, two. So you have a cause. Then the factor.
So it is a crampy pain. Your term is suggesting intermittent claudication. So
Yes.
our debate is whether there is clear. Have you taken enough history to say that there is no intermittent claudication? Straight away gone for the rest pain. That's what you are telling. Am I right?
Yes, sir.
So
I've
sir,
taken it.
Honorary sir.
So this exact that 1 month only history, 15 days back she developed pain and another immediately the ulcer. So all this is all little happening too fast, I feel. so
This
so
was
that part is
so
that part is little this thing and Gayatri. Are you hearing me, Gayatri?
Sir.
Do you hear me?
Yes. Yes, sir.
Abhirami.
this is Abhirami sir.
Abhirami. So,
Yes, sir.
claudication pain, they saw told that various three segments. Exercise induced
Yes.
pain to be
Yes, sir.
solved. To be precise, somebody does normally doesn't have pain and he walks
Yes, sir.
or indulges in
Yes.
activity because of muscle activity, they develop
Yes,
pain.
sir.
Then later
Yes,
on they
sir.
develop, even if they don't walk, then they develop pain. So that is called rest pain. Here your case says you clear cut you say there is no clarification at all.
Yes,
Straight
sir.
away down pain and next thing is migraine. So that means probably one thing. Oh, how old is he?
Sir, he is 65 years old, sir.
So
60.
even with his background of diabetes and other things, so many problems. I think he had underlying ischemia since long,
Yes,
and
sir.
he is
But
known to have atherosclerosis, and probably he was living with that. So
yes,
only when the acute phase came, he has come to you.
yes,
You
sir.
understand?
Yes, sir. Yes,
Probably
sir.
say for about 100% lumen size. He had 80% block already.
Yes, sir.
Now this has aggravated to 1995 now. See, he developed pain. So
Yes, sir.
once it reaches a critical level, it became gangrene. Do you
Yes, sir.
follow? So
Yes,
that
sir.
means we cannot take the history as the patient says that exactly 1 month back he was absolutely all right. Then he developed all these things. Huh? So
Yes,
at
sir.
your level it is okay, but remember when you categorically say there is no clarification, with all these things, it is little questionable. Huh?
So
So you have an open mind to think how
Yes.
everything will be scripted just like that, next, like that.
so
Yes.
blackish. What is that blackish discoloration, Abhirami?
Sir,
That means what?
yeah, gangrene, sir. The
Gangrene. Oh,
patient had underwent macroscopic death of the tissue, sir.
okay.
So definition.
Definition also will tell you.
Yes. What is the claudication pain due to?
So the claudication pain can be due to the narrowing of the blood
Now, what
vessels to the.
how is the claudication pain? Pain is due to
Pain is due
Pain is
pathology.
pathology. What something is
What is the
happening.
pathology?
what is the cause for rest pain? What is the cause for claudication pain?
For claudication pain is due to the insufficiency of oxygen to the muscles, sir.
No, this is
Whereas
what
You
pain
mean to
is
say
due to.
that is ischemic pain.
Pain is due to what substance?
P
Something is
substance, P
Ah,
substance, anaerobic
yeah.
metabolism, which
Oh,
gives metabolize a P substance, and the P substance gives the pain, sir.
okay.
Then
Next,
how
sir.
it is relieved? How it is relieved?
Sir, in the grade one, the P substance is washed away, sir. But in later stages where the P substance remains, you can either the patient to rest for some time, 5 to 10 minutes, and the pain will disappear, sir. Or analgesics could be given to the patients, sir.
So, this is a boys grading, okay, and it
Yes,
has
sir.
got only three grades, and rest pain
Yes,
is
sir.
not a component of the intermittent claudication.
Boy.
Rest pain does not come, okay,
Okay, sir.
only
Okay,
three
sir.
grades, okay. So, like Robin has clearly told, crampy pain
Yes, sir.
appears after exercise, disappears when you stop the exercise. The three levels, he has already told, he has pointed three level point is important. All these 3 points are important to define intermittent
Okay.
claudication. Okay, this is a Boyd's
Okay.
grading, three grades.
Yes.
This will not come under claudication. Is it clear?
Yes, sir. Yes, sir.
What is
Pain
the
over the
what is the difference, ma'am, between your claudication pain and rest pain?
So, claudication pain is while the patient is walking for a particular distance and the pain starts, or the
Exercise.
patient has exercised and the pain starts, that is
Okay. What is
claudication
it?
pain, which can be relieved by rest. But in rest pain, the patient doesn't do a activity, is in rest, but still the patient has pain, sir.
what's the rest pain? You said
Suppose
claudication.
according to you, history-wise, you say patient is having rest pain. What does it mean to you?
What is the cause for rest pain? You said claudication is by substance P and lactic acid, all those things. What is the
Yes,
cause for
sir.
rest pain? Again, you can also answer. You are a part of the team.
Rest pain mostly like crying of the nerves, like
Kind of.
the disease has the nerves are getting affected, sir. That can cause rest pain, sir. Crying of the nerves.
No, you have suppose let us say you have Abhirami, two patients.
Yes, sir.
So
Yes,
one
sir.
patient is having claudication pain.
Okay.
The next patient is saying I am having rest pain. So what does it mean to you?
So, claudication pain, it is due to the narrowing of the vessels and P substance.
No, that's all okay. No, I am asking these two patients, who is more critical?
The patient with the rest pain, sir.
Rest pain, that means it is a critical limb
Yes,
ischemia.
sir.
That is the message.
Critical. Yes, sir.
Somebody that doesn't do anything, still they have developed pain and they say means definitely he is in more danger of becoming gangrene or
Gangrene.
losing his limb. So
Yes,
the
sir.
critical limb ischemia I call.
Yes,
Abhirami,
sir.
just for
Rest pain,
clarity.
as issue-wise rest pain means it is more critical.
Yes, sir.
Abhirami,
Understood, sir. Yes, sir.
Anna told very clearly. He said rest pain is he says that it has critical ischemia. Whereas
Yes,
in
sir.
critical ischemia, in claudication will not come. Claudication is not a component of critical ischemia. Understood?
Okay,
Patient
sir.
with the interclaudication, they are yet to go for critical ischemia. Whereas patient with rest pain, they are having critical ischemia. You know that you understood the difference. What sir
Yes,
is
sir.
pointing?
Yes, sir.
Is it
Yes, sir.
clear?
Yes, sir.
So, sir,
That,
point very important point, sir. This is
that too with or without gangrene, ma?
With gangrene, sir.
No, no. Rest pain may be with gangrene or
Yes, sir. Without
without
gangrene.
gangrene.
Yes, sir.
So that has to be out.
whatever it
Yes,
is,
sir.
rest pain is a component of critical ischemia. Whereas
Okay, sir.
claudication is not a component of critical ischemia. Understood? No, that's what sir
Yes,
want to
sir.
point very
Yes, sir.
clearly. Okay.
Yes, sir.
So why pain over the course of the vein?
Sir, to exclude any varicosities or vein pathologies.
What pathology?
What
Thrombophlebitis.
Yes,
thrombophlebitis? No, you know, yeah, you know, heard about TAO?
yes, sir. Thromboangiitis obliterates Bursar's disease.
It eventually involves vein also, no? So it's a
Yes, sir.
thrombophlebitis.
Superficial and deep vein.
Okay. So anything to ask or we'll go to the next slide, Robin?
Yes, sir. What is the components of DAO, ma?
Components of TAO.
So,
What
Sir
is
said
the
already. No, sir already gave a clue. It involves the vein also.
Sir, it involves the veins, superficial and deep veins, sir. It
Then
involves the small and medium vessel arteries, sir.
not the deep veins.
not
Yes.
the
Then
vein, not the deep vein?
not the deep vein. Any other structure it involves?
One more structure in the limb.
Artery you told, vein you
Small,
told.
yes, sir.
Then
New.
What?
What else left?
What is remaining?
New.
sensation.
Sensation, yes.
Sensation.
Tingling.
Nerves, it involves artery, vein, nerves. Vein.
Nerves. It's called panarteritis.
Okay.
Understand? It involves all the things. Understood? Right.
Yes, sir.
You have heard about it? Panarteritis.
Yes, sir.
Panarteritis. So
It is
TAO.
also involved in vein and nerves. TAO.
Yes.
All three components
Yes.
are involved. Not deep vein.
Yes.
Deep vein, not deep vein.
Yes,
Okay?
sir. Got confused, yes, sir.
No problem. So go to the next slide, sir.
Yes, sir. Yes, sir.
Yes, sir.
Next slide, Pratika. Okay. Pain in the buttock, thigh, other limb. What it means for you? Pain in the buttock, thigh, and other limb. Why you want to talk
Sir,
that?
to locate where the narrowing is present, sir. If suppose the pain is in the buttock, you can think about iliac disease, sir. If it is in the thigh,
No. Abhirami, use the
yes,
word occlusion. Don't say narrowing.
occlusion. Yes,
So
okay,
it
sir.
is occlusion is in what level? So that gives
Yes,
the
sir.
hint. So
Yes,
first
sir.
line you tell us where is occlusion.
For buttocks, it is in the iliac occlusion, sir.
Okay.
For thigh, it is the iliofemoral occlusion, sir. And if it is in the
Syndrome?
calf,
What is Leriche syndrome? Heard about it?
yes, sir. Leriche syndrome is the pain that is in the buttock, thighs, and the patient can present with impotence, sir.
No, Abhirami, occlusion. Remember the word occlusion. Levin
Occlusion, yes.
syndrome, where is the occlusion? That's all.
Iliac occlusion, sir.
So bilateral it is.
Yes, sir.
So
Bilateral.
Okay.
before
Yes,
the
sir.
common iliac divides, the occlusion is at that level.
Yes, sir.
Understand? Right.
Yes, sir.
So why tingling numbness you asked for?
Sir, tingling, numbness, if any the patient is already diabetic, so I can think of peripheral neuropathy, or since there is the patient has wrist pain, I can think of any other thing called tingling, numbness over the
No,
limb, sir.
There is already
Abhi, your case is of peripheral vascular occlusive disease, yes? Like sir has already said, you have an artery involved, probably you have a vein involved depending on your pathology. Which is the most, or let me rephrase, which is the first structure involved because of ischemia? When you
Arteries.
have no blood, no oxygen. First structure that is getting involved because of ischemia.
most
Muscles, sir. Muscles, sir.
No, not muscle.
No.
That is why you're having tingling sensation or numbness first. So the muscle
No,
is
no.
uh,
Nerves.
the peripheral nerves get involved first.
Yes.
you
So
hear
what do
me?
you
No, hypoxia. Blood is very, very sensitive for that. Okay.
Yes, sir.
I'm sure you have felt this when you go and watch a 3 hour movie. Have you seen Durandar 2? I'm sure when you sit for theater for a long time with the chairs which are very cramped, you have the sensation like ants are
Yes,
crawling.
sir. Yes, sir.
We
Yes,
call it
sir.
paresthesia for us. The same thing, tingling
Yes, sir. Yes,
sensation.
sir.
Now the question to you is, like sir has asked, why do you have paresthesia? What is the reason for paresthesia? Obviously, we all do not have POD when we go to theater. It's just
Yes,
it's
sir.
a beginning evolving stage of say the body telling that blood is not going.
Yes.
So by the time we
Yes,
do
sir.
all this massaging and start moving like this, what is the reason for that? For this tingling sensation, numbness over your leg, not foot, leg.
Sir, may I, sir?
Yes, yes.
Yes,
Again.
yes, yes.
Yes,
Yes,
sir.
sir.
In this case, since there is ischemia present, there may be shunting of blood from the skin to the underlying muscle in order to provide it with blood supply. So that causes paresthesia in the skin over the toe region and
So
the foot.
basically, it's the shunting of blood from the superficial system to deep system.
Yes, sir.
Because of that, one area is getting sacrificed, so it's going there. So it's very easy to remember. Next, Abhi, whenever you present it, like no history of pain in buttock, thigh, and other limb. It's like you've mixed a lot of things. you go the peripheral system in order. That's why sir, Muthukumaran sir, he caught up straight away to that.
Okay.
If you're saying buttock, thigh, impotence, it goes together as Lerisius syndrome, no doubt. Then you
Okay.
go to the
Okay.
next system. And you go in order, it's like a head to toe, you go. Next,
Yes, sir.
why history of trauma or discharge from gangrene? Don't you think it's a different
Sir.
point? It's a different
Yeah.
point, right? Like no discharge from the gangrene. Agreed, because that is one of the features in
Yes,
gangrene.
sir. Yes, sir.
History of trauma is a separate feature. Now, the patient is 60 above. We do
Yes,
not
sir.
know anything else. You have not given us the the person history. Is he a smoker, chronic smoker?
No, sir. No, sir. He's not a
He's
smoker,
not
sir.
a smoker. So now we are having a problem in differential diagnosis. So
Yes,
what
sir.
if now maybe it's atherosclerosis? We do not know. Maybe
Yes,
there's a
sir.
diabetes, so maybe it's a diabetic problem. Diabetes is a triad, no?
Yes,
It's
sir.
it's sugar-laden tissue. That's diabetes. Glucose is one. Two is microangiopathy.
Yes,
Three
sir.
is neuropathy.
Neuropathy. Yes, sir.
Yes, this is the triad. So now, because of the neuropathy, the trauma is a factor there. That is a
Yes, sir.
precipitating factor there. So now we do not know what the diagnosis is. So I think it would be nice if you can split it and give us. So yeah,
Yes, sir, sir,
Yes.
please.
so that
No,
here it's like we are not sure. Like, is it history of trauma too? Is it a reason for that? Yes, gangrene. One of the causes for gangrene is trauma. We agree. A physical trauma is the cause for gangrene. But this patient is a mix. So we do
so
not.
to the
Yes, sir.
peripheral vascular disease, minor trauma triggers the event. So that is
Yes,
the
sir.
where,
Understood,
uh,
sir.
yeah, but you should split it. So
Yes,
chest
sir.
pain, palpitation, shortness of breath is for sleep thing for cardiac involvement,
Yes,
Professor.
sir. Cardiac involvement. Yes, sir.
Abhi,
Yes, sir.
okay, this is gangrene, no?
Yes, sir.
Why you are talking about discharge? Which gangrene you get discharge?
Wet gangrene, you get discharged, sir.
So you have dry gangrene and wet gangrene.
Dry gangrene, sir.
Here, what is your case?
Dry gangrene, sir.
How do you know it is dry gangrene?
Because there is no discharge, sir, and the
Hmm.
line of demarcation is
There is a
present, sir.
critical point, critical line of healthy tissue and gangrene tissue with a line of
Demarcation is present, sir.
very good. Right.
Yes, yes, sir.
So we put next slide.
What do you ask about chest pain, palpitation, or?
Sir, to exclude cardiac involvement, sir.
Hmm.
If suppose there is any narrowing or occlusion present in the coronary arteries, or yes, sir. So to
Arterial
exclude it.
problem. Arterial problem is a systemic problem.
Yes, yes, sir. Yeah, yes, sir.
So we put next slide, sir. Next slide. Pratisha, next slide. Okay, transient loss of transient. Why this blackout and loss of vision? Transient weakness of limbs. What's the reason? Why you want to check that?
So to exclude any occlusion in the brains or like stroke or cerebrovascular disease.
Why? Why this postprandial pain, melena, those two?
So mesenteric ischemia to exclude that, sir. To
Okay.
that cause, sir.
Okay.
Abhi,
Yes, sir.
yes, very good. Your answer is absolutely right. Just to make it a little bit harder for you, which type of mesenteric ischemia do you see? Postprandial abdominal pain, loose stools, and melena. That is profuse loose stools. The patient will come to the casualty that way. It's like he has never had this sort of loose stools in his life, he will say. Probably. What type of ischemia? You're right, it's mesenteric, but which type?
What do you know
So
what are the types?
the large bubble gangrene, the
So we
patient.
want to know if this sort of thing is seen in an acute problem or is it in a chronic problem?
Acute,
Could
chronic,
you
then
repeat the question, sir? Your
Is it,
voice,
is it,
sir.
yeah, I'm sorry, is it an acute problem or a chronic problem?
see, mesenteric ischemia can be acute, chronic, can be due to
Yes, sir.
hemorrhage, can be due to atherosclerosis, can be due to venous
Yes.
causes. Okay, so
Yes, sir.
Robin is asking which type you are contemplating by asking this history, chronic or acute.
Arterial component,
No, arterial
whether
only naturally, but chronic or acute.
it's a acute on chronic presentation
No,
maybe
no,
to
then now you are diplomatic, you are in between. Acute.
You are very diplomatic.
Robin, please explain because it is something beyond that level.
Yeah, so it's okay. It's all right, sir. I know. That's why I apologize to our first. It's just to make it because you said it is the right answer. It is in chronic mesenteric ischemia because this acute is a deadly condition. Deadly condition that the patient comes, he is not able to speak. In fact, the bystander might say something because severe bloody diarrhea, pain out of proportion to his symptoms are out of proportion. But postprandial is the clue there. The patient will say that I've been having this since a long time, and whenever I eat, I have this problem. But this time it was, yes, you're right. It is an acute or chronic because the patient has come to the casualty. You're absolutely right. Yes, very good. Yes.
Muscle pain. I welcome Tala. They joined from London. Tala, welcome to you. You can also participate in the discussion. Tala. Dr. Tala is a consultant in London. Actually, he was our
Hello,
colleague
sir.
earlier.
How are you, sir?
I'm fine. Tala, you can sirs are there. You know all of them. Manor sir, Robin sir,
Yeah.
Suman sir. So we also participate. Hope things are okay in London. So,
Yes, all good, sir. All good.
so why is your upper limb pain, Abhirami?
Sir, what, what question did you ask, sir?
No, upper
No,
limb.
Why upper limb?
upper
Why
limb
upper limb
pain.
pain? Why did you ask upper limb?
Sir, to check if suppose there is any occlusion over the arteries of the upper limb and
So for the sake of completion, basically your head to toe examination, you are
completion, yes, sir. Yeah,
Okay.
hit.
Okay, great. So next slide.
Abhyanga, can it not be vasculitis that affects generalized vessels? Did you
Okay.
think of vasculitis?
Yes, sir. I thought about vasculitis, sir, but vasculitis may not be it cannot. In my opinion, I thought it cannot present with gangrene or ulcer formation.
Okay, great. But vasculitis is
Thought like that, sir.
mainly upper limb and all, then lower limb. So you have to think of, but that eventually, that's the reason why you look for the upper limb pain also. Okay, ask the history of that. So we'll go
Yes.
to the next slide.
Yes,
Yes,
sir.
sir. Abhi, he has got
Yes, sir.
multiple problems. Remember, he has got CML.
Yes, sir. Yes,
He
sir.
is a
Yes, sir.
diabetic.
That's what
He
Yes,
is
sir.
non-tuberculous patient.
Exactly, UI.
Yes,
There's a
sir.
background
Tuberculous
of
patient. So it is might have
right.
the.
multiple system involvement at so many
Yeah,
things.
Yes, sir.
That's why he
Yes,
is
sir.
prone for developing
absolutely.
monoimmune
Vascular.
component, including vasculitis.
Already this
Yes,
is
sir.
last history is set to come that. We got a CML, no? So all the reason to look for upper limb. So all the reason why Taras asked that question because the systemic disease is there in the background. Okay. So we'll go to the next slide.
Yes, sir.
Yes, sir. Yes, sir.
So here is the CML, like sir told. So may probably all the reason to look for all these things. Then comes to the myeloma in chronic myeloid leukemia induced vascular problems, which we have to think of.
Yes, sir.
I'm not sure hematinic causes the vasculitis. So it also.
He is non-hypertensive also. And again, another component. So, tuberculosis.
So all factors are there. Only humans he has taken drugs, is it?
Yes,
ATD.
sir.
Not. So he's having back pain. Is it that?
Yes, sir. He's not actually. His chief complaints are not back pain, sir.
Okay. Also, obviously diagnosed, you are not asked. No problem. Okay. Details of spine because it's a recent onset spinal tuberculosis. It's quite common in diabetic patient, but how it is started with the history, patient was evaluated. You are not asked. That's okay.
So
That's not asked.
the patient just gave a history that before 2 months during a hospital visit they found out, sir. Other than that,
Okay.
patient did not give a clear history, sir.
About that. Detail about that. Okay. So we'll go to the next slide.
Yes,
Sir,
sir.
next slide. Next slide. So treatment is you already told imatinib, metformin. The next slide. Next. Surgery history, you said ray amputation, not race amputation. Robin, if I'm not wrong, just correct me if I am wrong.
Disarticulated.
It's a
It's a ray amputation.
not
Then
ray. Y apostrophe S is not there. Only ray.
Yes,
Okay.
sir. Yes, sir. Yes, sir.
Okay. Okay. Servant and black discoloration. Surgical history underwent amputation. Okay. 2 years back. So you said 2 years back he has undergone amputation. After that he was symptom free. Is it entire thing
Sir.
free? Same limb he has undergone amputation. No. All right. Current problem is
Sorry,
right side or left?
breaking, sir. I'm really.
Current problem is left side, no?
which
Yes,
limb
sir.
is affected?
Current
Right or
problem is
left?
left side, sir.
Which
Left,
side?
sir.
Left. Okay. Okay.
Left,
Current was
sir.
left. Right side is left. Okay, okay. Next slide. So family, she has told allergy history, she has told no any drugs or food. So we'll go to next slide,
Yes,
Robin.
sir. Yes,
Yes,
sir.
yes.
CML personal history, no history of smoking. So whole loss of weight, loss of appetite. So to the simple we know is a non patient is a non-smoker. So why he
Yes,
has
sir.
developed all these things also, you have to give reason. Simply, why is the what's the cause for PVD then
So it
in this
can be
patient?
because he is already an underlying diabetic patient, sir, which
Diabetes because of
could
diabetes.
precipitate any microangiopathy, and the patient
And
can could have developed atherosclerosis.
CML also can
Yes, sir.
cause all these things. Both CML and diabetes both can cause. So need not be smoker always to develop this.
Yes.
Remember, even though it's very
Yes.
common in smokers, did not be always smoker. Okay. So next
Yes,
slide.
sir.
Next.
Age wise is 60 plus now, ma.
Yes, sir.
So that itself is a elderly person, so prone for atherosclerosis. He's prone for
Yes, sir.
atherosclerosis, a elderly person. We added to that you have diabetes, definitely is having more chances of getting.
Yes, sir.
So that is a double-edged thing your patient is having. Okay,
Yes, sir.
right.
So history is the same thing. I think anything to ask to this, sir? No, no. We'll go to the examination, Robin.
Yes, sir.
Yes.
So next slide. We'll go to the Shaheen.
Greetings to all the respected faculties and the fellow viewers. So I'll be carrying on with the examination part. So general examination, the patient is moderately built and nourished. The patient is conscious and oriented to time, place, and person and is cooperative. There are no signs of pallor, icterus, cyanosis, or clubbing or generalized lymphadenopathy present. There is unilateral pedal edema present in the left foot. There are no signs of xanthelasma present. No signs of nicotine staining on teeth and gums present.
Next slide.
Vitals. The pulse was 83 beats per minute in the right radial artery, which was regular in rhythm, adequate in volume, and of normal character. The pulse was also felt in the left radial artery, and no radio-radial or radiofemoral delay was noted. Blood pressure was 100 by 70 mmHg measured in left arm in sitting position. The respiratory rate was 19 breaths per minute. The temperature is 98 degree Fahrenheit. The oxygen saturation was 99% at room atmosphere.
Next slide.
The patient was examined after taking proper consent in a language they are comfortable in and was examined in supine position with adequate exposure.
Next.
Upon inspection, there was no obvious muscle wasting in bilateral thigh and calf region. There was absence of great toe in right foot. A single 3 into 2 centimeter blackish discoloration in left great toe extending from the proximal surface of tip, involving the plantar aspect 0.5 centimeter above the base of great toe, with a clear line of demarcation is present, and there are no discharges seen or present. There were no restrictions of movements. No skip lesions were present above the gangrenous area. There were no ulcers present. Upon examination in both right and left lower limbs, there were no marked difference in the color. Skin appeared to be thin and shiny. The hair was absent till mid-calf region. The guttering of veins were absent, and the toenails were brittle in both the lower limbs, and the veins were visible. The peeling of skins was present in the left limb, lower limb, whereas it was absent in the right lower limb. And edema, when compared to the right lower limb, was present in the left lower limb. Berger's postural test. In right leg, there were no color changes observed upon elevation, whereas in left leg, marked pallor in the feet was observed upon elevation at an angle of 30 degrees. Moving on to palpation, the skin over the dorsum and plantar aspect of left foot is cold when compared to the right foot. The tenderness is present over the left foot. The gangrenous area is hard and mummified with no sensation, no crepitus, and no bleeding. There were no obvious muscle wasting or asymmetry seen, and both the mid-thigh and mid-leg regions were measured for their circumferences, and in both right and left lower limbs, it was 34 centimeters for the mid-thigh circumference And mid-leg circumference was 28 centimeters in right lower limb, whereas it was 27 centimeters in left lower limb. The capillary refill time was delayed in left leg by 8 seconds in all toes, whereas in right leg it is not delayed. The cross-leg test was performed and oscillatory movements were seen in both the limbs. Berger's angle in left lower limb is 30 degrees. Peripheral pulses were examined in both the left and the right lower limbs, and the dorsalis pedis artery, posterior tibial artery, and anterior tibial artery in left lower limb there was absence of pulse, whereas all the other pulses, namely femoral artery, radial and ulnar arteries, brachial artery, subclavian artery, common carotid artery, and superficial temporal artery, were felt in both left and right lower limbs. The popliteal artery was feeble in the left lower limb. Next slide, sir. Yeah. The inguinal lymph node region were examined and no palpable lymph nodes were present. Examination of the peripheral nervous system. All the muscles in both upper and lower limb showed a grading of 5 upon 5 for power, and the reflexes were checked in both the upper and lower limbs, which was normal in right and left side. Examination of the sensory system in both right and left lower limbs. In the right lower limb, when compared to the left, the fine touch was present, whereas it was absent in the left great toe. Crude touch similarly was absent in left great toe. Proprioception was present in both and right and left lower limbs. Pain, when compared to right, was hyperesthetic along the line of demarcation in the left lower limb. Systemic examination. Cardiovascular system, upon examination, there was S1 and S2 heard and no murmurs were heard. Respiratory system, normal vesicular breath sounds were heard. Per abdomen inspection, upper abdomen examination, it was soft and non-tender, bowel sounds were heard. CNS, no focal neural deficit were seen and skeletal system was normal. Summary, examination findings, specifically the rest pain, mummified gangrene with a clear line of demarcation, cold skin temperature, and a positive Burgess test at a low angle of 30 degrees, strongly supports a diagnosis of critical limb ischemia due to peripheral arterial disease, likely exacerbated by the patient's long-standing diabetes and multimorbid history.
Uh, uh, okay, tell me the diagnosis.
Sir?
Diagnosis.
Provisional diagnosis. Chronic limb ischemia due to peripheral artery disease in left lower limb with dry gangrene of left great toe caused by diabetes mellitus or cerebral fever.
Okay, go back to the examination. Okay. Back, one more back. Okay, anything comment on this, sir? Robin, sir, Muthukumar, sir, Sir Manohar, sir. Jantalasma, whether they need to mention unless it is there.
One is, in this case, not mandatory.
Mandatory. Jantalasma, if it is there, you mention.
Otherwise, you have to leave it out.
Otherwise, there is no need to mention. Shaheen,
Yes, sir.
okay. No, sir, nicotine staining on teeth and gums. Unilateral, why unilateral pedal edema?
Sir, because the left foot is affected and the right foot is quite normal, so and gangrene is also present in the left great toe, so the edema was present in
The
the
right side, there is no disease. But why he has undergone amputation right side?
I was about to ask. Yes.
like
For what reason, what indication he has undergone amputation?
sir, for trauma-induced ulceration followed by gangrene due to diabetes.
Okay, sir, trauma-induced gangrene.
Sorry, sir.
Trauma-induced gangrene.
Trauma-induced infection and gangrene.
Okay.
Trauma-induced infection and gangrene.
Induced gangrene, sir.
Okay. What does that mean to you? That kind of history.
Sir, It means that previously he had, because the patient is known condition of diabetes mellitus,
Hmm.
peripheral neuropathy might have been present and the trauma might have not be considered seriously.
Hmm.
So the trauma resulted in infection and gangrene too, which
Why? No, the gangrene part. Why is it important?
uh, so history of similar illness in the past,
So that
which
is already there is he is having a very strong peripheral vascular disease. He went in for gangrene in the opposite limb,
yeah,
isn't it? That means his peripheral vessels are already damaged.
damaged.
That is 2 years back.
Yeah,
So after 2 years, he would have avoided much more damage in the left limb also, no? So that probability you have to keep in mind. Okay. Next slide, sir.
Next slide. So vitals, everything.
Shane, the patient is having pain since 1 month, etc., with gangrene, right?
yes, sir.
The patient is cooperative.
Well,
Breast pain, no? Patient is cooperative with.
no, sir, it was quite difficult to elicit the burgers.
Yeah, so that would have been interesting for the examiner, no? Because patient is conscious, yes, oriented to time, yes, but he's in pain. So
Yeah,
that would have been interesting because you are examining the case, you could have mentioned. Then in the pulse, rate, rhythm, volume, character, condition of vessel wall is an age special. Yes,
Visual wall.
Important condition of vessel wall.
6 things. Then delay. Delays.
Okay, condition of vessel wall important. Correct.
yes, sir.
Okay, it's SpO2 in the right arm. Have you checked the SpO2 in the toes? Right toe.
No, sir.
No. Okay. Yeah, just
Okay. Next slide.
next slide. So, sir, anything to comment on this? They are comfortable. Okay, made comfortable. Okay, adequate.
Nice picture, sir. But both the dorsal and plantar aspect taken.
Taken
Very,
care.
very nice. Yes, sir. Next slide.
Next slide. Next slide. Next slide. So, inspection. There is no muscle wasting, is it? Are you sure? Because you see the limb. No
Yes.
calf muscle wasting or thigh muscle wasting.
No, sir, not present, sir.
Not present. You have compared both sides.
Yes, sir.
Okay. Absent Reto, you have given the reason.
You have compared now. So probably what he was before, we don't know.
Okay, sir.
And second thing, and even your colleague present that she said there is no loss of weight and this thing.
Yes,
So,
sir.
with all this morbidity, definitely there bound to be some amount of loss of weight. No, isn't it? Logically, I'm telling.
What is line of demarcation? Shane?
Sir,
What is the meaning of line of demarcation?
the line of demarcation is basically seen in gangrene. It separates the living tissue from the dead due to the formation of granulation tissue.
Viable and non-viable.
Viable.
What type of line of demarcation you see in the dry gangrene?
Sir, in dry gangrene, the line of demarcation will be sharp and neat, sir.
Clear cut line of demarcation.
Yeah.
Clear. And it is aseptic. Aseptic, clear cut, clear line of demarcation. Whereas in wet gangrene, septic and unclear line of demarcation. Okay.
Okay.
Okay. Go to the next slide, sir.
Yes, sir.
So this is no wasting, Robin, because there are skin changes in the both limb. No fat loss is there.
Shaheen, can you tell us the signs of ischemia?
Signs of ischemia, yes, sir. The skin will be thin and there will be loss of subcutaneous fat, and the nails will be brittle in nature with transverse ridges present as seen in the image. And
What
then,
about loss of hair?
sir,
Loss of hair.
yes, sir, I was
First,
going to say that. Yeah.
inspection first is the color. Color is the first thing that you see. Then the second thing that you see is the hair. Subcutaneous fat you will not see. That is below. So from top to bottom, it's easy to remember that. Yes.
And the loss of hair will be present.
Yes, very good.
Uh,
You said transverse ridges in nails, no?
yes, sir.
Do you have any particular name to that?
For that.
Ridge name. Abhirami, you can also
It's a
answer.
very tricky thing because it is seen in surgery and medicine. There are two organs. Two organs common to both departments.
Buse lines, sir.
Very good. Yes, absolutely right. Yes, Abhi. Views lines. Yes. Where do you see? Absolutely right. Where do you see?
Where do you see that? Abhirami?
We
It
gave
is
two organs. One for
across the
medicine, one for
nail
surgery.
plane from side to side, sir. It is deep
No,
and
no, no.
horizontal.
No, Abhi, you always describe a question, don't describe it. Just answering.
He is a good pathologist, sir.
Yeah. Just where do you see? That's it.
Condition, which condition?
condition.
which is
There are two organs you see it.
Ravi, you can give answer to
the
them.
core high fever, uncontrolled diabetes,
No,
zinc,
no, no. Shane, you can try. No,
zinc
you see,
deficiency or
you see
peripheral
it, and
vascular disease
you see it, and it's one of the signs of peripheral ischemia, like Shaheen has said. But the question was, where do you see Pio's lines? You see it in liver failure and renal failure. Liver for us, kidney for medicine department. Simple.
Okay, sir.
So why skip lesions, Shaheen? Why you are interested in that?
Sir, because if the proximal arterial, if there is stenosis present, there will be like kind of a gangrene formed above the area of the gangrenous part, which is left great toe.
The ischemia or occlusion is more proximal than what gangrenous area you see. Okay, much more proximal actually. So why restriction of movements you look for?
Uh, Sir, in order to know the if any like joint is like kind of like bone involvement is present.
A bone involvement restriction of movement. Which joint you look for?
Sir,
Which joint movement you look for?
sir, in this case, we look for the metatarsal phalangeal joints.
Okay. Okay. Sir, anything to add on to this? We'll go to next slide, sir.
Yes, sir. Next slide.
Next slide. Okay. One ankle joint movement is also important. Okay.
Yes, sir.
Everything,
So
whether
again,
they,
your
whether
second
the
point, your second point, see that skin thin and shiny. You missed that. So I was waiting for that. Skin appearance in ischemia always the skin will be thin and shiny. So this you have mentioned in the second point. Understand? Yes. Why it is thin and shiny? Thin you told with loss of subcutaneous tissue. Why
Yes,
it is shiny? Why it is shiny? Any idea?
Not
why
sure.
is shiny?
I'm not sure, sir.
So reduction in blood flow can make the skin shiny, sir.
So if Abhi's blood supply goes, Abhi will become shiny. Is it so?
Again, Abhi is explaining the question.
Sir, no,
Again,
sir. Severe nutrient and oxygen deprivation, sir.
so
So, why it is shiny?
So your theories are all fantastic, really. Abhi. Great.
You can answer, sir.
Oh, sir, you tell, sir, please.
Okay, this why guttering of the vein?
Sir,
Guttering of veins.
Vein.
yes, sir. To like kind of exclude the vein causes.
So the guttering of the vein means it's the complete collapse of the vein. In a
Yes,
normal individual, even if you elevate the limb, there won't be complete collapse of the vein. The ischemic limb, when you elevate the limb, no, there will be complete collapse of the vein. So that's a severe ischemia. Okay, that is only partial collapse of the vein, even in the elevation. Okay, other thing. Sir, another thing, sir, whether they can put this one in the table form, is it accepted in the exam? Just I'm asking for the student's sake. So, Robin, is it okay to put this one in the table form in the exam? Whether they have to write in the lucid continuous flow of thought presentation.
Sir,
Just
actually,
asking.
first step, they generally have to say it. They won't. I've never seen like this.
Yeah, that's what they put the table. So you can just say color is like this one.
Yes, you have to recite it.
Only pulse table is yellow. Shaheen, okay? It's okay, it's accurate, but in the exam, usually you will tell right side, left side, like in a lucid language, okay?
Two components, guttering of vein and peeling of skin may not be mentioned, sir, I feel.
In the examination, you can describe the affected limb.
Yes, sir.
Then you can go to the opposite limb, normal limb.
Yes, sir.
Here, left lower limb examination. Next, right lower limb examination.
okay.
Pulse will be in the table form. That's absolutely right.
Yes.
So next slide. So what is it? What it suggests? What type of pallor you look for? What it is explained clinically actually?
Sir, we call it as a cadaveric pallor.
Cadaveric or marble-like pallor.
Marble-like.
Cadaveric pallor. And
Very good.
Now what will happen? Red
We
test.
found, the leg will get into a cyanotic hue presentation due to cyanotic congestion.
So that suggests this one angle of insufficiency. But plantar food should be very clean. Otherwise, if it is, especially in the agriculture farmers, plantar food may not be very clean. So in such situation, may not be able to clear cutly do this vascular test. Okay.
Okay.
Yeah, very, very nice photograph, sir.
My photograph they have put good details. So next slide. So palpation, anything to comment, sir? Palpation tenderness present over the left foot. Why tenderness?
Sir, in order to see along the arterial tree if there is any pain present, to know the area of obstruction.
Tenderness is a feature of ischemia.
Sir?
Is that a feature of ischemia? Tenderness is a feature of ischemia, or you want to check the bone or artery?
Sir, for arteries, checking the arterial tree.
No, pulsation.
That is pulsation, no? That is for pulsation.
Pulsation, no.
Yes, sir.
You said tenderness.
Yeah.
It's a feature of ischemia, no.
Ischemic part will be tender.
Okay, sir.
Code you have put equally, you have to always mention how far proximal this cold limb is extending. Where it is becoming how far proximal up to the middle of the leg, where you have to tell that. This coldness, how far you have checked.
Okay, sir.
So you tell the finding in this patient.
Yes, sir. The tenderness was present over the left foot.
Coldness.
Coldness. Yes, sir. The coldness was present like 5 centimeters below the knee. It started 5 centimeters below the knee till the left foot it was present.
So it is up to the proximal leg it is cold.
Yes, sir.
And then beyond above it is warm. This is what you are telling.
Yes, sir.
Above knee also it was cold.
Above,
Below knee.
Above knee.
sir. Below knee it was cold.
Okay. Right.
No muscle wasting or asymmetry.
You clearly mentioned from the dorsum of the foot at the ankle, leg, upper, lower third, middle third, one third, upper one third, knee and above knee.
That's very important.
So the gradual coldness, that shows ischemia, isn't it?
Okay, sir.
Excellent.
That line is important. Up to where coldness is extended proximally.
Okay, sir.
And I should compare with the opposite limb.
Okay, sir.
Any finding, extent is important.
Extend level and comparison.
So next slide. So go back. So right mid thigh circumference, yes, almost same. Okay, next slide. You got measure from the bony point. All of you know that, no?
Yes, sir.
The thigh. Okay. So capillary refill time delayed in the left leg 8 seconds or to cross leg test. What happened cross leg test in this? Performed your return. Finding is it same, equal or different?
Sir, it was seen both limbs. It was like the oscillating movement was observed, sir.
It's equal.
Yes.
It's oscillating.
Yes, sir. It was also.
Means what? What is that? What is the test called as? Any name for that?
Fuchs 6 test.
Cross-leg test of fusing. No.
Next slide, sir. Good. Next slide, sir.
Yes, sir.
Okay. This is important. This one. He said it's a right side. Everything is felt your tail.
Yes, sir.
Only left side. Only unilateral disease. That means.
Yes, sir.
Sir, anything to ask you? The details, I think.
This thing should come first, I think, sir, before
Yes,
all
sir.
other palpatory things. This peripheral artery pulsation should come first.
This is the most important. All students should write in the triple form like what is written. Always from right, this from below upward, not from above downward. Always in the same order you have to write. And you have to know where you will feel, how you will feel, and over which bony part you will feel it.
Yes.
You have to know clearly in the table form, right side, left side, present, feeble, not felt like that. So you have to know where you will feel, how you will feel, technique, and over which bone you will feel. Okay.
Yes, sir.
So.
And tell me, dorsal SPD is where you feel. Sorry.
Dorsal SPD is where you feel.
Able to feel it lateral to the extensor hallucis longus tendon on the proximal, on the plantar surface of, on the proximal surface of the foot.
Plantar surface.
Lateral surface feel, dorsal surface.
I mean dorsal surface. Sir.
Dorsal surface.
Lateral surface below.
Yeah, yeah. I got it.
Dorsal effect of this over navicular bone and medial cuneiform bone. Same thing, posterior tibial
All pulsation in the dorsum of foot. Nothing is in the plantar.
plantar. No pulsations are tried to feel in the plantar aspect. Remember, only in the dorsum and side, of course, below the medial malleolus, you can feel the posterior tibial. Popliteal where you will feel.
Sir, it will be felt in the popliteal fossa.
Oh,
Position of the patient.
Yes, sir. We should flex the knee like 40 degrees and the heel should be positioned on the floor. And then we should use
Supine or prone position.
Supine position or prone position.
both the positions we can examine the patient, sir.
But ideally,
in the supine position.
supine or prone.
Prone.
Prone, okay.
Ideally prone. Abhirami, you have got any contest to anything to contest against him? How to
No,
examine? Ideally, should be in the prone position with the flexion of the leg over knee joint. Usually in the lower part of the pelvic fossa because you got a flat surface.
New theory, Abrahami.
Sir. No, sir.
No theory.
But to make things easier, to avoid patient to lie down in supine prone position, many times it is accepted to do in the supine position also, where you have to flex the knee, then palpate in the lower point with the thumb placing over the tubercle of the tibia. Then if you flex the fingers in the lower part of the pelvic fossa, you feel it. Okay,
Yes.
so that is how that you feel. Ideal position is prone, but the
Okay.
conventional position is supine with the flexion of the knee joint. Okay.
Okay.
Then femoral artery over
Sir,
femoral artery over which bone?
femoral artery, sir, it is felt in between the anterior superior iliac spine and pubic symphysis below the inguinal ligament.
Below the bending point. Okay.
Yeah.
Over which bone? Or neck of the femur.
Neck of femoral.
You have to just flex the hip joint and adduct joint and then feel it. You have to relax the fascia and feel it. And radial ulnar, similarly brachial, peripheral artery over which bone?
Sir, clavicle, sir, mid clavicular line.
Over which bone?
Bone.
Bone over the clavicle.
Oh, Abhirami, you are agreeing with him? Circular artery you are feeling over because clavicle is superficial, no subcutaneous bone.
artery must be superficial to the bone.
Yes, sir.
Tell me what bone?
It is against the first rib, sir.
Against the first rib, above the clavicle, against the first rib, Shashi. It is not over the clavicle. Okay, you are wrong. Okay, it is over the first rib, above the clavicle.
Okay, sir.
Circular artery is what we are told. Common carotid where will feel?
Sir, in the carotid triangle, like in front of the sternocleidomastoid at the level of sixth cervical vertebra.
Against.
Against the carotid.
Transverse process of cyst.
C6 vertebra. It's the tricygnate tubercle. It is called as. Remember that name? So there is a lot of debate whether to use that word or not. If this is carotid artery, common carotid artery is learning over the tricygnate tubercle. That is over the transverse process of the C6 vertebra. So we should have a prominent bony surface to feel a pulsation anywhere. So it is not in front of the sternocleidomastoid. It's a medial to the sternocleidomastoid muscle. It's the level cartilage. Remember, okay?
Okay.
Not in front. You are telling in front. It is not in front. It's a medial. Okay. So over tricygnate tubercle. Okay. There is a debate whether to use that word. You can always use because it felt over that. You don't require to feel that bone. It felt over that.
Okay, sir.
So superficial temporal artery felt where?
Sir, in front of the tragus of ear.
Over which bone? Or zygomatic bone.
Like,
It's the over zygomatic bone. It divides into posterior branch. So superficial temporal artery is felt over the zygomatic bone. Its branches are anterior. Posterior branches are felt over the temporal bone. Okay. So in front of the tragus. So this is the most important slide, like Manoj already told.
So thank you, sir, for highlighting each and every arteries are as detailed.
Very important. Very important.
The most important, this is where the students get caught, including postgraduates.
You should write it in paper form. Always
Spend time in practicing this so that if at all they ask you one specific artery, you will be able to answer.
You should know where to feel, how to feel, or which bone to feel for each pulsation. Okay. Right. So if you go to the next slide, sir.
Yes, sir.
So lymph nodes, okay. For why you want to check lymph nodes?
Sir,
Why you wanted to check lymph nodes?
sir, patient was a known case of chemo. He's undergoing chemotherapy for case
For
of
that, okay, CML is there. You can look
Any
at
any other reason in this patient in particular reason you went for lymph nodes?
uh,
if there is no CML, still you check for lymph nodes. If it is so, what is the reason?
uh,
Inflammation. There is inflammation. No inflammation is there in the limb. So inflammation may spread into the inguinal lymph nodes. Here,
Yes.
Regional means which one you mean?
sir,
Which group? Which group?
Regional.
inguinal lymph nodes, how is it classified? Which group? Inguinal lymph node, how is it classified? Abirami. She's relaxing now. Her job is over. So everything is Shaheen has
We
to.
have horizontal, vertical group. Which group is involved?
Which group is involved, Shaheen? There is horizontal or vertical? It's a vertical group.
Vertical.
Limb
Yes,
is
sir.
lower limb is drained vertical, horizontal perineum, other area, internal wall, and so on. Okay, it's
Yes,
vertical
sir.
group. Okay, right.
Abhi guessed right. He's good in guessing, sir.
Right.
Next slide, next slide.
Yes, sir. Next slide. So again, it's a good photo, sir.
Excellent, excellent photo.
Very nice photo of the limb, clearly clear is there. Next slide. So peripheral nervous system, everything, the sensation you have put absent. You said pain is absent, hyperesthetic absent, sensation is absent. You said. So what it means?
sir, like, the sensation is like kind of absent over the left greater in the ganglion area.
Right, we are not, that's right. You said, I understand your finding, but what is the cause for that?
Sir, nerve injury,
Nerve injury.
main scavia of nerves as that, and peripheral neuritis present due to
Right,
diabetes.
sir, neuropathy in a
Diabetes.
diabetic neuropathy, no. But interestingly, right side is not involved. Only one side. It is usually they are bilateral and like a that bilateral involvement is very common. Only left side neuropathy, probably due to diabetes it is there. So what is hyperexcitability means what?
Sir, like an action or a stimulus which will not elicit pain usually or will cause a medium range of pain will be like kind of increase.
No. When you hyperexcitability means when you touch, you will feel the pain. So other sensation will feel actually.
Already Dr. Raman told you in detail about what is the hyperesis.
Hyperexcitability already. Yeah.
I have one question, Shaheen.
Yes, sir.
You said absent in left grip or group touch. It is a gangrenous part. How do you expect that?
He has written line of demarcation, sir.
No, examination of sensory.
Yeah, gangrene is.
When I get part is gangrene, do you expect fine touch, group touch?
Dead tissue.
That is no.
Wait, one is gangrene. Once it is gangrene, do you expect that?
No, sir.
Nothing. You cannot feel anything. No. So you should do little proximally.
We should do.
Beyond the line of demarcation, if you check for fine touch, group touch, it is acceptable. You understand?
Okay, sir.
You don't test for touch in dead tissue.
Okay, sir.
Once you see gangrene, it's understood it is aesthetic. There is no sensation.
Absent, proximal to the line of demarcation would have been more appropriate, I feel.
Okay, sir.
Absolutely right. Sir, sir, understood no what sir is telling.
Yes, sir.
Proximally, have you checked the sensation in the foot and leg?
Yes, sir. We did check, but we didn't include it here.
No, what is that? It's okay, but what is the finding? It's
Finding.
normal or abnormal?
Sir, it was like.
Blood.
Sir?
It's red sensation.
Yes, sir. The sensation was like over the line of demarcation, it was present only, sir.
Okay. So proximality is now. It's important. The sir has told very clearly. You have to check proximal to the gangrenous area.
It is very highly appreciable, sir. Each and every component they have made. Excellent detailed presentation. The only thing this is a gross mistake, I feel.
Yes, sir.
Over a dead tissue, don't check for fine touch, group touch.
Okay.
Examination of sensory system is very, very important. This is one common thing which students miss.
Right.
So you have not missed even a single component. Everything has been meticulously written. So only this thing is totally clear. You understand?
It is a
Fine
process.
touch, crude touch over a gran and dead tissue is no point.
Proximal to that gangrene.
Proximal to that is acceptable.
Okay, sir.
Up to the, you said no, limb is cool up to the middle of your proximal leg. Up to there, you have to check the sensation.
Okay, sir.
Whether it's normal, reduced, all those things. That's what the sir was very clear point. Don't forget. Okay.
Okay, sir.
When you describe the grade 2, all these points you can include it.
Okay.
Try no sensation, something like that you can include instead of putting it here.
Explain. Here you have to put the proximal part. Okay. Okay. Next slide. Next slide. So that is system is like okay. Next slide. So summary, same thing as mentioned. Most of the things, sir, properly. Multimorbid history means what?
Sir, the patient having diabetes and
Okay, hypertension,
CML,
CML, okay.
Tuberculosis.
hypertension. Yes.
Next slide. Next, so chronic limb ischemia with the dry gangrene of the left great toe caused by diabetes mellitus. Bar, why you have put bar? And you can put no.
Okay, sir.
Not one of the things, can be both also, no?
Yes, sir.
But what is the some peculiarity in this patient?
Sir,
The finding is considered. Only left limb is involved, right limb is not involved.
okay, sir.
So, understood. No, right limb is said, pulses are felt, you said. Nasal, posterior tibia, everything is felt, and you said gangrene is due to trauma.
Yeah.
So, how will you explain that? Only one limb disease, atherosclerosis in a diabetic patient. So, that's the only. If whether he had a trauma in this side, you have to know.
Okay, sir.
Shane, the toe.
Yes, sir.
Was there a callus present there in his toe? The torsional, the
No.
plantar aspect, any callus?
No, sir. No callus was seen.
You ask history?
Yes, sir. I asked history, and upon examination too, like the gangrenous area involved much of the grade 2 in the plantar aspect, so there was no callus seen.
So the entry of the, so there is no trauma at all.
No trauma in left foot, sir.
No trauma in the left foot. Okay. So that's only one limb is involved. There's something peculiar. As you are telling, right limb is normal. There is no absence of pulses in the right limb. You said perfusion is good in the right limb. Looks like actually. So, sir, we will go to the investigations, Robin. So,
Yes, sir. Yes.
okay. Next slide. So, who is Abhiramia or Abhirami tell?
Yes, sir.
Abhi is enjoying. Yes.
Sir, no, sir. I'm listening only, sir.
Help your colleague.
Yes, sir. I'll say the investigation, sir.
Okay.
Yes, sir. The management, evaluation and investigations, ankle brachial index, arterial Doppler with B mode duplex scan,
What is
CT
B mode
angiography.
means what? B mode means what?
Sir, the vessel wall is also
No, B
examined.
mode duplex scan. What is the B stands for?
Abhi, please stick to the question. No explanation. Just stick to the question.
Shaheen? Yes,
Sir,
okay.
what is the B in B mode?
Sir, brightness.
Yes, it's the brightness mode. That's it. Very good. Very good.
Other
Is it duplex? You
other
put as arterial duplex because that is Doppler with B mode.
B mode.
There is no arterial Doppler with B mode duplex scan. That is like everything. This duplex scan. It is understood.
Other mode, not also M mode, that is for echocardiography, motion mode. Okay. All other area what we use surgical side is a B mode, is a bright mode. Okay. Echo for cardiac system. CT angiography, what findings you look for? CT angiography.
Occlusion, sir, blood flow. If suppose there is any occlusion, there is no blood flow in the peripheral arteries, sir.
Okay. Then anything else you want to look for?
Both CT and MR angiography.
Yes, sir. Any narrowing of the.
You told narrowing, occlusion, agreed. Any other thing you want to look for?
So that
Collaterals.
Very good, excellent. Because only one toe is gangrene.
Yes,
In
sir.
spite of the occlusion and other things, the rest of the leg is still not gangrenous. That means what?
Collaterals are formed.
There is ischemia, but there is blood flow because of Collateral.
Collateral.
Collateral. Okay. So, what is distal runoff, Abhirami or Shakeen?
Sir.
Distal runoff. Yeah, have you heard about a word called distal runoff?
Angiography finding.
Angiography finding distal runoff. Shakeen Ali?
No, sir.
Abhirami?
No, sir.
What is the purpose of doing angiography?
Patency of the arteries.
It will be narrow or obstructed.
Yes,
Narrow.
You want to know the segmental length of the segment or something like that?
Yes, yes, sir.
What about the distal vessels? You want distal vessels should be normal, or suppose they are also occluded, what will you do?
So, length of involvement, collaterals, distal runoff. It is the amount of time.
Beyond the point of occlusion, what is the course of the vessel? If the vessel is also gone, there is no point in salvaging the limb. So we should know the position of the vessel beyond the site of occlusion. So that's called as distal runoff. Here it is written CT angiography and MR angiography. Why not plain angiography?
Why not conventional angiography?
What is angiography?
Sir, to
Conventional, you will do no when you inject dye to the vessel and see
Put something inside the vessel and then take a picture. That is conventional angiography.
and
Plain, you just mention angiography, that means conventional angiography. Here you mentioned CT angiography and MR angiography.
yes, sir.
Is it interventional or it is something else?
CT and MR is mainly for evaluation purpose. Okay. Conventional mainly for therapeutic purpose. Okay.
So here we don't do conventional. Any idea why we don't do? It's already a diseased, damaged, occluded vessel. So if you put a contrast inside, it will precipitate further occlusion and may result in further damage or go for the entire limb, may go for gangrene.
It will aggravate the disease process.
That's why we don't use the interventional angiography in this kind of a case. So
Yes,
we
sir.
don't have a CT or the MRI angiography.
What is DSA? DSA.
What is DSA?
Have you heard about DSA?
Digital.
Abhirami?
Sir,
DSA.
DSA, sir.
Digital.
It is also angiography.
Digital subtraction
Angiography.
angiography.
What do you subtract?
What you subtract? You subtract bone actually. Okay.
So the image comes, you delete with the computerization, you delete the muscles, bones, and only the arterial structure is
The arteries are seen.
seen, so that you can see the clear tree, arterial tree with the branching and collaterals and obstruction and occlusion.
Yes,
Other
Distal runoff.
Okay. Other tissues are subtracted so that it will delineate only vascular pattern. Okay.
yes, sir.
Among these investigations, if it is available, DSA is the best.
Okay.
Yes, sir.
If at all it is available among these investigations, you should mention DSA if available. Okay, right.
Yes, sir.
Because
Guys, what is the normal Doppler pattern
Yeah,
that you
sorry.
get? What are the normal Doppler pattern? Because we've talked a lot about CT angles, but you mentioned Doppler first. So what is the normal Doppler pattern that you expect?
The report, what they give.
Normal Doppler pattern. Normal pattern.
Abhi, don't give us the mechanism of Doppler. Nahi chahiye. Just tell us what you see.
Again, what is the normal Doppler pattern? Understand what is the Dr. Kala Ahmed has asked the question.
The three things you see, what is the normal?
1, 2, 3.
Yes, sir has given clue. Finish. That's it.
That's all.
Monophasic, triphasic, biphasic.
She is deadly, sir.
Normally, what do you see? Do you see 1, 2, or 3?
In different arteries.
So for you, if they do angiogram, what you will get? Abhi's report will be.
She'll get a triphasic one because
Sir
it's
has
not.
given clue. Yes, see, Shane has given a help you, but you are not helping Shane.
Sir,
Triphasic one. You will get all full. You will get.
You are normal, so you will get triphasic.
Triphasic. So you should be able to.
Because it is 9:20. I will just quickly finish. We will not ask. Ankle brachial index is very important for you guys. It's not an investigation. It's a bedside tool. It's very easily reproducible in the patients. You should also, supposing the patient has diabetes, which you already know, which is a policy problem, and the levels are very high.
yes, sir.
Is there any other thing that you can use other than ankle brachial?
Toe brachial index.
Very good. Yes, you can use a toe because that vessels are not very rarely involved because of this thing.
Separate
Yes,
cough
very
pulse.
good.
Okay.
Yes.
Next slide.
Treatment.
Okay. Treatment.
Disarticulation of left great toe. Further treatment based on
Why
angiogram.
you want to recirculation? Why you don't want amputation of the great toe? Because in a vascular system, if you are able to recirculate, you will able head will get exposed to blood head of the metatarsal.
I don't understand the
No,
question, sir.
disarticulate means you remove the gangrenous part. What sir is telling, the head of the toe will be there inside. Because there is avascularity, it will not heal. So better you should go for that.
You remove the head of the toe or not? First toe. In a
Yes, sir.
vascular disease.
Yes,
So
sir.
you have to remove. Only then
Yes,
you
sir.
can,
Yes, sir.
only then you can close that wound, stump.
Yes.
We have to remove the head of the first great toe or any toes in a vascular system. So it is the amputation, not the recirculation. Okay.
Yes.
So because the raw surface cartilage will not heal because no blood supply there.
Okay, sir.
So in a vascular system, there is recirculation is not a common surgery. It's an amputation. You have to remove the head of the great toe, head of the metatarsal. After whatever the toe you want to do, you have to remove the head. Cartilage is there. You have to remove that. So it's the amputation, not disarticulation. Remember, very clear.
For this also, day amputation only is done, sir.
Ray amputation only. So it is a ray amputation only. Okay, not disarticulation. Never do. Okay. So further treatment based on the drugs and revascularization procedures. What revascularization procedure you can contemplate here?
So bypass graft could be
Okay.
like balloon angioplasty stenting could be done, sir.
Okay.
Or the since the femoral arteries and femoral artery is viable and it is not having any narrowing, you can have a femoral-tibial arterial graft can be
Okay.
placed, sir.
Which graft you will use?
Sir?
Which
Sir,
graft?
What type of graft?
Great stiffness vein is the gold standard, which can be kind of derived. If it's not available, if any vein is not available, we can go with synthetic materials like Dacron, polytetrafluoroethylene.
PTFE.
Patricia, next slide. Patricia, next.
Thank you, please.
Okay, just go through that. These are different treatment aspects.
Yes, sir.
So, sir, next just drugs are important. Next, he has already told balloon angioplasty possible. Then, of course, neovascular already they have told graft, saphenous vein graft, reverse saphenous vein graft. Then, of course, grafts, synthetic grafts, Dacron graft, usually used, and then the distal part you use a PTFE graft, polytetrafluoroethylene graft. It's a graft. These things are important. Other than that, you have to remember profundoplasty and other things. So just discuss. Meantime,
Procedures some mentioned in some books is your omental. Drag the momentum to the tunneling so that brings some blood supply.
Especially for KO, where nothing is possible.
Yes, sir. Yes, sir. And periosteum, you can use the periosteum also.
Trying, sir. They have tried that, but finally it's the direct vascular surgery. Procedures are better actually. So that's treatment aspect also important. There are many questions they ask in the treatment aspect, profundoplasty and other things. Okay. Sir, comments, Robin, Bhattakumar, sir, Mohammed, sir, comments about their students.
Sir, I give full credit to both Abhi and Shoaib, sir. Excellent presentation. One of the best presentation I have come across, and meticulous each and every component they have analyzed. Nothing left except for these things. And hats off to Abhi and Shaheen.
Thank you, sir.
Savita is near to my place, so I will somehow make a point to visit them and compliment them in person. Congrats to Dr. Kutumar.
This is difficult actually. PVD case is difficult for them.
Difficult for undergraduate level, sir, and they have discussed very well.
Rather confusing it is. Of course, they were, but they presented well. They thought and answered actually.
Yes, sir. And Abhi especially managed very well, sir.
Yeah.
Fully supported by Shaheen. Shaheen talks like Amitabh Bachchan with a deep voice. Congrats, sir. Muthukumaran, sir. Very great presentation, sir.
They analyze well, sir. They
Yes, sir.
prepared well. They
Yeah,
prepared.
full
Credit goes to them only.
yes, full credit to the both the students.
Both presenters.
Please congratulate. Congratulations.
Yes, sir.
Thank
Just
you, sir.
my slide, sir. Next slide. Pratisha, next slide. So all these things are I will not discuss. Actually, the commonest cause TAO in detail you have to know. That's what Robin has discussed. So what are the T components? So just go through the book. Is a detail they may be asked. In this case, it is atherosclerosis. If it is in the what happened? If it is in the younger age group, smoker, then you have to think of TAO. Not in this, but it will be discussed in the exam. So you should know the detail about the TAO also. Although smoking, pan, diabetes, triad of diseases already Robin has discussed. Limb salvage or amputations, that's also important. Next slide. Next, Pratisha, next slide. So history, next slide. So age, claudication pain. Now already we had this claudication. Remember color change, claudication meaning, Boyd's grading. Boyd's grading is for claudication, not for rest pain. Remember, we have discussed that. And different
Yes,
types
sir.
of claudication I am not going to discuss. Neurogenic venous may mimic. They are different. Just go through the book and find out what they are. They are different. Maybe asked in the exam. Rest pain details, gangrene details, you have to ask numbness. Thrombophlebitis already you have mentioned. Veins are normal. This is also important. Next slide. Next. Next. Okay, so past history already you are told drugs, evaluation, cardiac disease, diabetes, trauma also you are told actually. Most of the things they have highlighted. Next slide. Next. So smoking is important. Smoking index, which you have not discussed, they will ask in the exam. Years of smoking into number of cigarettes, packet index, years of smoking, number of packets per day. Okay, here one is years of smoking, another is this one. So the smoking index is important. Just clarify it in the from the book. They may ask in the exam. Next slide. So family tree, everything will details. She has already highlighted very nicely. Actually, the tree is important. Next slide. Next, so write brief summary of the history always in case sheet. Do not use short form. That's important in the exam. Never use short form like a pickle, HOPI, CM, all those things. Don't write. Sir, that's why they use it. All those short forms nowadays. Don't use short forms in the exam. Again, inspection palpation. I'm just putting it all these things in this slide will show very clearly. Guttering of vein, deformity. Then blood vessel from below up in the table. Already they have done that. Lower limb tests are I've mentioned that, and upper limb examination I'm not going to detail it. Different tests are there. It is not relevant in this case, but when upper limb is involved, all these physical tests you have to do. And as wasting, limb girth length, they mentioned that. Palpation of thrill you have not mentioned. It's important. They mentioned femoral artery thrill and bruit. If you put here felt, normally it is felt, there is no need, but just mention in the femoral vessel, thrill is not there, bruit is not there. It's a yes, you know this. Okay. So femoral artery palpation and auscultation you are not mentioned. That's one point that's important in the lower limb vascular disease. Next slide. So this table gives everything about how to examine. Next slide. So already they have told how to examine, palpate and details. This table is important. Next slide. This label is important. Next slide. So note both the lower limb should be examined. Ascleral femoral renal carotid for regional lymph node you have mentioned. Gait and joint movements. Gait you have mentioned it, whether it's walk is okay or not important. You have not done that. Abdominal examination for aneurysm. Sister, for what to look for? Many times they will have, especially in atherosclerosis, they may be having silent aneurysm there above the umbilicus in the midline. So deep palpation may feel the expansor pulsation. So that is important to look for actually in the family. Previous scar, previous sympathetic scar or other scar, surgical scar. CNS, already you have told those things. Next slide. Next. So diagnosis, give a complete diagnosis. Gangrene right great with ischemic ulcer in right toe, with critical limb ischemia. So definition of critical limb ischemia, sir has already told. Claudication does not come in there. So rest pain for more than 2 weeks, I think, not respond to any drug. If the ankle pressure is less than 50, toe pressure less than 30, so just go through the book. The definition is important for you. And these things, B mode, the brightness mode, remember, the non-invasive, what to look for the biphasic. CT and dynamic conventional, already sir has told that conventional dynamic CT and MR. DSA full form, we have discussed the digital separate angiography. Other assessment may be echo, ECG, DMT. Next slide. Next. So treatment drugs, I'm not going to discuss, can go through the book. Angioplasty, you are told. Surgical direct thrombectomy and the meanings you should know. For Pondaplasty, saphenous vein graft, in situ reverse arterial graft, you are told. In there, not much role, like sir already told. Lumbar simple omentoplasty, you can go to the book to how exactly it's done. Other management is important here. Diabetes management, CML, what drug, whether it's what is it causing any added problem. Amputation, not disarticulation. Remember, you do amputation, not disarticulation here. So next slide. Next. So grading of claudication only 3 grade. Okay. Rest pain does not come in that. Already Robin has told 3 component.
Yes,
Crampy
sir.
pain develops only when muscles exercise. Pain
Yes, sir.
disappears in the exercise stop. This is the what already we have discussed is important. Don't get confused. Okay. Next slide. So remember all these things. Rayner's phenomena we are not discussing because of want of time. Definition, all these things you should know. Club, necro, sequestrum, line of death, skip lesions is important. GA symptoms, stroke feature, you are told, both limbs. Look for femoral drill, body, ABPI, you are discussed. Cutting of the vein, all other things we are discussed more or less. Angiogram, we are discussed. Stenosis and fusions. Next slide. So angiogram, important thing is, most important is angiogram. X-ray may, if there is osteomyelitis, suppose severe ischemia, large artery occlusion, small artery occlusion. Remember also the TAO, angiogram. So chronic and acute disease, again we have discussed, Robin has discussed properly. Anticoagulant therapy, whether there is a how to palpate each and validation distal proximal, already we have discussed that. Next slide. Next slide. So this is skip lesion. See that back skip lesion is important. See different upper limb involvement also can occur. The dry gangrene with the line of demarcation, here is the wet gangrene, skip lesion is there. So all these things you have to look for. It's a very large topic. Read on books, everything, and learn actually. They have presented. Next slide. They have presented very well. Next slide. So my book of current edition, sir has given the put the forward. New edition, 8th edition. Clinical book has got a lot of videos, a lot of photos and video to examine. Every examination video is there. I request all to subscribe my website. It's free. So already around 500 lectures are there. Of course, live session to join everybody. Probably next live session by Sir Robin's college. They present probably very good thing. I'll discuss with them and put. I thank Kumar sir, hello, their students to present. They present very well. I thank my professor, Professor Manohar sir, Guru sir, Robin, my dear friend. Very, we will have always very good interaction.